Sylvie, the Director of Terminology for the Gravity Project. It is my honor to welcome you to the Gravity Public Call on this last day of March. Believe it or not, the year is swiftly coursing by. Next slide, please. Awesome. So we welcome everybody to the meeting. There are some just background kind of housekeeping stuff that we try to address. So most importantly, there's a lot of you who tend to join the call. We have about 130 people. So due to the large number of attendees, we always mute folks upon entry, and we ask that you remain muted to avoid background noise. The call is being recorded, and the recording is always available on the Gravity Confluence page afterwards. You are encouraged to actively participate in the discussion. We are an open public collective using the chat feature. We do ask that you send chats to everybody. I really try to work hard to include any elements from the chat into the conversation. And just send the chats to everybody. Just make sure that if it's to me, I might read it out loud. And we do ask as a courtesy that we limit side conversation in the chat, just because we really want to make sure that we're focusing on the topics at hand. So connecting in the chat and then having conversations offline via email, etc., is totally great though, because we do have a pretty, we do serve as kind of a watering hole of sorts for this work. Next slide, please. This is our common antitrust practices slide. Next slide. This is just about project participation. We do have a growing number of members, and we invite everybody to officially join the project. If you want to check whether you've already joined, because we've been up now almost 3 years, if you want to check whether you've already signed up or if others from your organization have signed up, please review the existing membership at the second link. And then for any other Gravity Project information, visit the last link. As you can see, the amazing project and program support team is putting all the links in the chat box for you to follow. Next slide, please. Just a nod to our project founders, grantors, and in-kind supporters. We are a collective that depends on granting and support from our federal, private, and otherwise colleagues. We have lots of in-kind support as well. I want to specifically give a nod to our friends at the AMA. So thank you everybody who is a current member and a current donor, and we really appreciate all of your support. Next slide, please. And as a classic collective, where we're not even a nonprofit because we're really just an assemblage of folk working toward a common aim, the Gravity Project's always seeking and is currently seeking funds to finish out our 2022 operations. So we really just rely on our sponsors for sustainability. So if you are interested in learning about sponsorship, you can either send an email to gravityproject@emiadvisors.net or visit the Confluence site, and there's a lot of information there as well. Next slide, please. There is a abbreviated agenda, but I'm loath to say it might not take the full time, because at the moment I say that, we always do. So we'll cover some announcements. There's just specific things that if Evelyn's on the call, she might be able to address. There's no new introductions. We're going to go through project schedule and overview. And then we're going to really just dive into terminology. You'll note there's nothing new on the horizon regarding policy or tech today. The technical team is deep in ballot reconciliation. If you go to the SDOH-IG meetings and preparing and considering pilots. So just it's just focusing on terminology today. Next slide, please. Next slide. So I don't know, Mark, I saw you were on the call. Do you want to give a quick shout out to the amazing session you convened with our amazing friends next week?
Happy to. So the Gravity Project is going to be on some stage, some room at Health Data Palooza on Monday, April 4th. If you're going to be there, it's at 12:15 to 1 p.m. Gravity's own Asha Emanuel and Chris Grasso will be there with me to give a behind-the-scenes peek at how you all make miracles happen. So look forward to seeing you there, and do come up afterwards if you're in the audience and let me know that you're there. I'd love to meet you in person as well. Thanks, Sarah.
Yeah, Mark, I want to thank you for organizing it and just want to give another shout out to the many people in this work that make it possible. We are a community that works on this labor together, so I'm really looking forward to that session, really highlighting the depth of our bench and that that count. This is just a nod to register for ONC's SDOH Information Exchange Learning Forum, which just kicked off and is running through July. I don't know if Evelyn wants to give any other mention on that. Um, Evelyn, do you want to speak to that?
Yep. So we kicked off. ONC has been working on an SDOH information exchange toolkit. They hope to publish as a national resource. And right now they're hosting monthly webinars or learning sessions through this forum, March through July. We just had one there. They have, if you go on the link, you can see that they have a place where you can register for the meetings, but also sign up to be part of smaller subgroups to inform. So there are foundational elements. I think what's really important for the Gravity community to know that we often hear and we appreciate that Gravity is working on many things, but what we don't work on is governance, right? Foundational elements that are important to actually establish this level of information exchange. And that's what this toolkit will incorporate, right? What are the things entities need to think through as they're establishing, for lack of a better word, community information exchanges or platforms or infrastructure to support the capture and exchange of this information. And so that's what the Learning Forum is for. I'll just, in the interest of time, I'll jump into the others. They're mostly what I've asked to add here. The other part is just announcing the upcoming CDC SDOH Public Health Use Case Workgroup. All are welcome to join. It is very much like a subgroup under Gravity. We will officially kick off April 20th. It will be a different work group. So right now you can find the CDC Public Health Use Case landing page within the Gravity Confluence. And in this will be 8 meetings bi-weekly where we will work on a business case and use case for using SDOH data for public health for chronic disease. And then the fourth bullet, Siren has a call for proposals for racial health equity and social care meeting. They are convening a group for fall, and so proposals are due April 22nd. And so please do, as Siren being our co-founder of the Gravity Project, we encourage you to participate if you can. And last but not least, eHealth Exchange Innovation Grant. So for those folks, we often hear about where is their funding available. This is $550,000 are available to organizations that want to demonstrate the use of FHIR for information exchange. So again, that would be very helpful as we start to look at recruiting entities to support our pilots. This will be funding made available for you. Thank you, Sarah.
Yes, Evelyn, there's one other question. Our dear friend Lucy had a question regarding whether the ONC will circle back and have more presentations to us regarding governance, or maybe the best thing to do is join those information exchange learning forums.
Yeah, Lucy, yeah, great question. This was exactly, ONC had the listening session with the Technical Advisory Committee. So this is what they're doing. They're now taking it to the public, right? But they can come back, you know, if they have, as they get feedback from the public at large, they may want, before they publish, they can, as a strong supporter of the Gravity Project, they can leverage our governance committees to get additional feedback. But I do encourage you to follow, and everything is publicly available, so you can also review it offline.
Wonderful. Thank you so much. It is really interesting to just see kind of Gravity kind of sitting in the middle of all these different activities. One of our friends called us just almost like we're a social determinants of health action group, which I think is really interesting about how we basically are forming these consensus groups that are involved in many different things that are working toward the same end. So thank you so much for the announcements. Center of Gravity, Mark. Nice. All right, next slide, please. All right, so Mark or Evelyn, would you like to describe this next opportunity?
Oh, yes. So we, at the beginning of or end of last month, we had a public call for nominations for the Gravity Executive Committee, and we would like to thank our Gravity community at large for sending in nominations. We still have 2 vacancies to fill. So we want to let you know, and actually there's a correction, Mark let me know. We actually, both of these are 1-year terms. So it's not a patient for a 3-year term, it's a 1-year term, meaning running from April next month to March of next year. So we're seeking nominations for a patient consumer advocate as well as a provider. And so if you can send us your nominations by tomorrow, that would be great. This is following our process where we have it in our operational guidelines that we need to request nominations from our Gravity community.
And just as a member of the PMO, the Program Management Office, I want to just say this is a really crucial voice. So this is where all of our stakeholder voices really center in strategy and finance and direction. And so we really want to make sure that folks kind of fill these terms and really are actively involved, because as you know, we really try to make sure that everyone has a voice, and these provider and patient consumer voices are so critical in that work. So please put your nominations in, and we can't wait to have you become part of the team. Next slide, please. All right, and then we have gone over this, but Gabby, I want to honor your work here. If you want to speak quickly to the pilot affinity work groups and the pilot work we're doing.
Right, absolutely. Good afternoon, everyone. It's great to virtually see you all. So as you know, we're getting started with pilots, and we are looking for entities that are looking to test the Fire IG as it relates to the system's roles on the IG listed referral source, care coordination platform, referral recipient, and referral recipient light. We are very close to launching the site. In order to be all encompassing, we are working on some use cases to provide a little more of guidance on what pilots we're hoping to test, which is the coded terminology developed by the terminology team, as well as the technical specifications for data exchange through the Fire IG. We'll be in touch. If you're interested, please continue to contact us. We are extremely excited to get started soon. So the Confluence site will be posted and shared with the group once it's live. Thank you.
And this is Sarah. I just want to state that from the terminology standpoint, the idea for having this the terminology feedback, clinical feedback group came actually before the pilots had kind of kicked off. And so one of our thoughts is integrating that work into the existing pilots work, because it is all about pilot testing, tier 1 being testing of that terminology, and just trying to make sure we're all synthesized. So look for more information to come about terminology testing in specific, and I'm late to the game there, which is why it's the least defined. But thank you, Gabby, for that work. So Dan McGovern, more specifically for the provider position, does that mean someone from a provider organization, or does that mean the individual must be a clinical provider? So I want to kind of hold up both options. We definitely have recognized the need for provider organizations in some of our outreach and advocacy. We specifically are appreciative of having the AMA and the AAFP. The AAFP is just sunsetting, but so I would say either, and then we will analyze the submissions and go from there. So either representing a clinical position and direct clinical care, or a holistic representation from a provider organization. Dan, did that answer your question? Oh, yes, wonderful. Next slide, please. Oh, lovely. Oh, yeah, this is just a shout out to the to the weekly Fire IG meetings. That's where kind of we go through the technical specs of the IG and resolve ballots. Those meetings happen on the HL7 calendar on Wednesdays. That's kind of the sister to this meeting. Next slide, please.
Hey, Sarah.
Yeah, hi.
Hi, sorry. Quick question for you on the slide previous when we were talking about pilots.
Yeah.
Is there a quick, what's the difference between the pilots and the Connect-a-thon?
Is there a quick
Yes. So Connect-a-thons they're also referred to as hackathons, where developers, implementers get in a room together and they exchange information within their systems, right? So it's not in a real world setting. Pilots are actually when you're working on site. So you think of a deployment where someone's doing in a sandbox and they're actually working on site, right? So we call them real world pilots. So it's not just the implementer with their software or their platform going in, it's actually end to end with all the users. So that is the difference. And pilots tend to be 6 months to a year versus a connect-a-thon, which is a day or two activity of testing.
Perfect. Thank you.
Thank you, Evelyn. Any other questions here? All right. Next slide, please. So here we are working through health literacy, health insurance status, medical cost burden, resolving the ballots from SDU2, working on technology, terminology, and pilots, and planning for future connect-a-thons. I want to note that those gray areas in the fall, like that you see to be determined, expect one of the sets of domains that we've talked about to be dropped into that by the next time we come back around. So it's time to make sure that we're solidifying that. And just as a reference, again, we have 2 different coherent sets of domains that we have on the ticket. One really community level concerns such as food access, neighborhood safety, digital equity. And then the other was covering elements of toxic stress and minority strain and discrimination and bias. So those are the 2 sets of information we've already been approved to work on, and we will come back next week or in the next meeting in 2 weeks, and you'll be seeing that work to come. So our work is ever ongoing. Any questions on this slide? All right, next slide, please. Any questions before I move on to the next thing? Okay, next slide, please. On to terminology. Next slide. And next slide. We have a quick update here. This is a repeat of the slide we gave before, but we really want to highlight the opportunity for comments. So as you know, we submitted the ICD-10 Coordination and Maintenance Committee meeting in March. Comments on the gravity requested terms have to be submitted no later than May 9th as a direct email to NCHS ICD-10 ICCM at cdc.gov. We did, as usual, provide a just generic comment letter that you can reference and take whatever text you desire. You can slice and dice if you want to give a specific comment to a specific element. You can use that text there. A copy of the final agenda containing the gravity submission you can be downloaded from this last link. And it is fairly robust. So just to make sure you know, we start on page 81. The reason why we transition to the final agenda is there are differences, as there always are, between what we request and what is finally published or what is finally seen. This happens with all of the terminologies, I guess least with LOINC because it's so straightforward. But with SNOMED, CT, and ICD-10, the submission we place is not the submission that eventually sees the light because we work with the different organizations to refine things. So the best way to see what was actually presented at the committee meeting would be from the direct download from the CDC. And we do look forward for comments and please support. We've already gotten some comments from friends that CC'd us on their emails, so thank you so much. Next slide, please. Oh, so Lolita, that is a great thing. So technically speaking, I'm not allowed to say exactly what's going to get implemented on October 1st until they do the formal release, but we do know that some of the terms from our previous years, a previous submission, both our 2021 September submission and some of our elements from October are likely to be part of, well, actually it's our year ago submissions from March that are likely to be part of 10/1/2022. There are likely to be not very many from the 10/1 submission this fall, but there is upcoming code and we know that. We just can't tell you what it is yet because the final work of the CDC has to go through. There also were some elements, if you remember, that were not seen. So some of the elements of specifically regarding perpetrator codes, those were not brought to the committee in March. We are still working with the CDC and our subject matter experts on those elements, and you should see them come to a future meeting. I know you understand. Lily is one of our very engaged terminology friends, and we're very grateful. But I can promise you that what you see coming out this October should be helpful in our grand goals and mission. Next slide, please. All right, so now we're getting into the work of terminology presentation. So we were working on our 3 domains all at once: health literacy, medical cost burden, health insurance status. And the real objective before we step into end-to-end review for health literacy next week is to analyze and make sure that we get all submissions we possibly can, especially regarding health literacy. That is the homework. You can see in green is the homework. As always, it's please submit your methods, please submit your screening tools, please submit your desired diagnoses, because we need to make sure that we have them for a robust set. Next slide, please. Next slide. And next slide, stepping into health literacy. Just to ground this work, I want to give a little context. I had the honor of participating in a TEP with many friends from Gravity, which was a digital health equity TEP with Johns Hopkins yesterday. It was really lovely to see much of our work here in the health literacy space aligning with the work of that very, very advanced TEP from our friends at AHRQ and NCQA. So it's nice to know our community is out there and doing this kind of work, not just here in this meeting, but also on a national scale when it comes to implementation and guidelines. So this is the slide you've seen. We always try to make sure that we commonly define things. This is the definition for personal health literacy. That has not changed. Next slide, please. I want to just note that we have created a pathway towards addressing the sticky wicket of organizational health literacy. You'll see that in future slides. In our meetings with our health literacy subject matter experts, it was very, very clear that the movement, as with most things, is to assign the action toward the structural forces. So to not point the concern at the patient, which is a personal health literacy concern, but to really point the concern at the system, right? So it's almost deemed unethical, and that's something that I removed from this slide, to just focus on personal health literacy, and that makes sense within the group and our mission and ethics. So the problem is organizational concerns must have organizational interventions and organizational solutions. It becomes a little bit difficult when we're talking about person-centered terminology. We think we have a solution. We're excited to present that to you on future slides. Next slide, please. This is again a call. You're going to see this again. I said it in the homework. I'm going to say it now. So we do have a really lovely set of health literacy screening tools, referencing the AHRQ, referencing the BU Health Literacy Toolshed. We do want to make sure we have health leads in there as well. We do want to make sure that we have any submissions that might be out there in the ecosystem. So if you are using a health literacy screening tool, please submit it quickly so we can get it as part of end-to-end review in 2 weeks. Next slide, please. We've added, since we last saw you, you'll see this on the updated master, the short assessment of health literacy, both the English and Spanish version, and a rapid estimate of adult literacy in medicine, the short form. This is based on review of AHRQ references. We've also added, as I mentioned, all the health leads health literacy elements. This includes the recommended question that's already in LOINC, and all of the alternate questions, which come from a precursor of a very, very robust screen called STOFHLA or STOFHLA. So you can see all of those on the master that's on the Confluence right now. This is important just to reference as we head into end-to-end review shortly. Next slide, please. This is where some of our sandbox work is happening. I want to remind folks of what I was saying earlier regarding organizational literacy, the requirement to name it as something that has to be addressed and where the intervention occurs, but the difficulty of signing organizational elements attached to a person. So we've thought about it, and we have some ideas regarding how to do that. So you can see the difficulty demonstrating health literacy concept remains, right? So that's the focus on the person. There are no changes in the ICD-10 and ICD-11 options. Those remain. You can see the problem with health literacy is both bold and not bold, because it exists in ICD-11, but it is yet to come into ICD-10. I'm sorry, my cat is letting me know they're here. You can hear them in the background. This is our idea about how to represent organizational responsibilities at the person level, right? So there are similar codes to this in SNOMED, and so there is precedent for this, but this focuses on the organization's need to meet the person, and it still would be a health literacy concept. Requires translation services to support health literacy, which is different than requires interpretation services to support health literacy, translation regarding documents, interpretation buying activity of a person who's serving as a translator. Requires digital education to support health literacy. This is an organizational element that focuses on that digital divide we've been talking about, and requires plain language interventions to support health literacy. So this specifically is about making it simple, right? So a lot of the literature on health literacy is not just about adding translation, interpretation, or doing this activity. It's literally stripping down the complexity of the things we say in the clinical and community spaces just to make sure the person can understand. So this is our approach, right? Because all of these elements would then be able to attach to the person, but they would represent those organizational responsibilities. And so we are testing this. It feels good so far, and it seems like our friends on the slide think so as well. I want to just give room for conversation regarding this because this is like a leap from what we had last time. Does this make sense to everybody?
Sarah,
Yes?
hi, this is Lucy. Requires plain language interventions. I certainly agree with that. I'm wondering if another requires could be slipped in here. Requires culturally appropriate language interventions. The fact is that some people, that plain language often devolves into fifth or sixth grade level. And there are some people who would benefit from a little more complexity. And just to be very personal about this, when I look things up, there are often buttons that say for consumers, for providers. Personally, I find the consumer explanations, I think I'm talking about government websites mostly, like NIH, they're too simple for me. So I go to the provider button and I don't necessarily understand anything on it, but I get more out of it. So I'm wondering if anyone else would think that requires culturally appropriate language interventions is something to be added here so that we are recognizing that there are a lot of different levels of ability to interpret language out there.
I think that sounds wonderful. I do want to, so well, I think we should, I first want to, I want to honor that that is true, right? I want to hold up what Teresa was saying regarding assistive technology and mention that we do actually include that in our programs. It's a very good point. And what we'll do, I think, Lucy, is put that in the hopper. Good interpretation should include cultural adaptation, but not all culturally appropriate language requires interpretation. Does that make sense?
Yes.
Yeah,
Yes.
so I want to make sure, so from a scientific perspective, I hear what you're saying, and we're going to bring that back and see what we can do. And Teresa, I do want to honor the fact that I think assistive technology is really, really important. And we actually included that in our programs, but it's not here. So got it. Okay. Anything else? And Mark, I appreciate that. Okay. Does seem like a good direction to go, which is it really took a group think to get here. I'm sensing yes.
Sarah,
Hi,
what?
Matt.
Hi, how are you doing? What would you do if there was an intervention and the patient still could not understand again and again, like so that the patient was essentially incapable of understanding the directions, or they had a medical proxy? And it may be going outside of the health literacy realm, and that's out of scope. But I just wanted to know how this relates to that.
Do you mean okay? So we have to be a little bit careful. Are what I hear you saying is you're looking for solutions where language alone does not meet the needs of the person. Is that because we have to be careful not to focus too much on implementation because that would be outside of scope. I mean, I could put on my clinical hat and I could tell you.
I didn't mean implementation. I meant there's got to be a code for the patient is not unable to make health decisions by themselves for whatever reason. It maybe this is not a literacy issue. Maybe the patient has dementia or something like that. Or there might be a version of this where you, after providing education or other health literacy interventions, that they still don't understand. And is there a code for that? Does that make sense?
Yeah, so I think that is beyond the scope of health literacy per
Got it.
se and would be
Got it.
addressed in other ways, but I hear what you're saying, right? To someone who works in the clinical space. Sonali, we are also still thinking about where provider education is needed. However, in this level, we're talking about the person, we're trying to figure out how to attach provider responsibility to the person level. There's a lot because and we might have to step out and address organizational provider level interventions elsewhere. And this is mostly just because we're bound by our model where we have to be we follow a line between the person's diagnoses, the interventions for the person, but trying to attach organizational responsibility to them. So we want to say yes, 100%. As a provider, I understand that, but we're trying to find the solutions for within the bounds of our model and our build. And then, Sonali, does that make sense? Okay. And then domain is health literacy, not HIT, with flagging meeting requirements. Exactly. So this is why this is where we're you'll see this on a future slide. We're talking about the balance between digital literacy and digital health literacy. And so there's a tension there that we're working, really trying to figure out how to fix a sticky wicket. But Mark, I totally understand what you're saying. So plain language seems ill-defined, but it has a definition. And Mike, I want to apologize for not putting it here, but it does. And maybe it's very much a definition in the literature and in practice. But it's also, we played with some other terms and they seemed diminutive in a way that was not really honoring the responsibilities. So maybe if you have other ideas with references, that would be great. But we did top around a few other things in there. All right. Okay, any other questions here? It seems like we're on the same track. There's some things we're missing. There's some things we need to consider. There's some things we're missing that we need to add and some things we're missing that we know we're missing, but we don't have a place for them right here because of our model. And as always, just because doesn't fit doesn't mean we don't recognize its the responsibility to address it. Like part of what we do is call to light things that need to be addressed that are outside of our scope at present, but put them in parking lots to figure out how to address them in the future. Okay, so I'm gonna keep on going for the sake of time. Here I could fill a whole hour and a half of just terminology. Next slide, please. So I want to I think this one came from our friend Tom. So we had able to demonstrate health literacy as a finding. And again, some of the wording here is in flux. We're not necessarily attached to the words themselves. We really wanted to make sure that again, we had a organizational literacy element and goal represented at the person level, which is basically we've done our job. Like the system has done its job to meet the person where they are. Consume is kind of something we're hashing out. But again, so this is not just the person can demonstrate health literacy, but the system has done its job to meet the person and support their goals. So the problem with understand is from a health literacy perspective, it's not just understanding, it's applying, right? So the full definition of health literacy, if you look back a few slides, is understanding and applying and using, right? So maybe we should just use, we did talk about using all of those terms, but it's really difficult to use ands and lots of commas when we're talking about terminology. There is a desire to say like one thing briefly without commas because ands are discouraged. So, but that's why it's not just understand, is because it has to be apply. Or maybe we should just have it be apply. But that's why it's not just that, is because really it's about using the information and not just understanding it. Lisa, does that make sense?
So Sarah, this
Well,
code,
my concern with consume is that consume for me just means that you took the information in, whether you understood it or not.
Yeah, so I hear you. So I'm gonna, yes, consume is awkward and we're still trying to figure it out. Um,
my
so
comment really picks up from there. Thank you, Lisa, for opening this window. This code, when there is one, or these codes, are going to be filled in by providers who are in a patient encounter. It's really interesting to me to think about how they are going to make this judgment. Health information can be conveyed verbally by the provider, can be conveyed by the provider in the form of booklets, can be conveyed to the patient in the form of the discharge summary, which in my experience now is including pages and pages of quote health information about whatever condition you presented with. So the idea that apply and use, I can't imagine how that's actually implementable by the provider, able to demonstrate in the provider's informed opinion is in itself a really culturally complex requirement.
So I do want to state, so we don't just imagine the provider stating these goals. So ideally goal setting, so able to demonstrate what's currently in there. You can see that it's bold. And again want to caution our wording needs to be fixed here. But we imagine these terms also coming from patient-centered care planning. Like this is my goal, right? So being defined not just by the provider or the team member, but by the person themselves. And
So
then
you imagine saying, do you understand this? And I say yes, because I want to please you and go on to my next task. Or how are you imagining that this code will eventually appear in the EHR? The patient doesn't fill that in.
well, yes, they can in shared care planning though. Yeah. So if we just the same way we have food insecurity as the goal for and food security as the goal for food insecurity, right? I'm not just diagnosing a problem, I'm not just applying interventions to the problem. I'm identifying a goal we're collectively working for that meets the needs of the person. I'm sharing that goal with the care team. This all happens now, right? So I have shared care plans for all of my critical patients across care teams across my whole health service area, and those goals are patient voiced, and we work on making sure that they're the center of what we do.
Yeah, I don't see this any different than any of the other problems the patient may have. The patient has an issue with health literacy, and then we're going to apply the interventions and measure against that goal, like we do for any other problem, such as pain or whatever.
Yeah, or like, physical therapy, functional status goals. Um, I do like the ideas Teresa's forming out here, but mostly, Lucy, did we answer your questions? Did I answer your question?
Sort of. Enough time on that. Thanks.
I am here, as you know, to talk further. But I wanted to state that the attempt here is to again state something where we're meeting the patient specifically on an organizational basis. Yes, and teach back is a lovely element. It could be a specific goal, right? Yeah, yes, because it would be specific technique to demonstrate understanding, right? That's a really good idea. All right, any other questions here? All right, so carry on. Next slide. Thank you so much, friends. So we recognize that that term is complex, and we're working on it. There are some new interventions, document translation services, state health literacy programs, the HEAL program, which is the national program, telephone and relay services, language interpretation services, and reading services for people with disabilities. Many of these align with existing elements in the 211 LA taxonomy. And there are really robust definitions. We want to thank Tom for some of the groundwork for some of these submissions. Tom Page, who's a member of our Interventions Council. Some of them actually just came through our own research. And then as with things usually, we roll elements that might be too specific or not specific enough on 2-in-1 taxonomy into things that are actually digestible. We have yet to analyze these for the actual people. So as you know, as we work with interventions, we think not just about programs but critical roles. I always try to highlight the fact that we built the community health worker role, which I'm really, really proud of because that wasn't there before our work. So again, these are some of the things you'll see on the master list, and you'll see them kind of built into our structure of interventions, refer to, education about, etc. And these again are all, you can imagine these applying specifically to that organizational literacy element. Like this is what we need to do to support you in your health literacy goals. Any questions here? Okay, and all of these again have definitions on the master so you can understand the program. Next slide, please. So this is a repeat of a slide we've had before. It is impossible in this day and age to separate digital literacy, digital health literacy, and health literacy. We've had a lot of conversations regarding whether we do what we've done sometimes and maximize and try to shove it into the last minute into this work, meaning digital literacy. But we really are thinking that what we'll do instead is really focus on that being part of our the area of digital equity in the fall, right? So not just covering access to internet services, but also covering the ability to use them. That would be very coherent. And so that's our thought right now. But we do want to hold space for the fact that we know that we can't get health literacy right with ensuring that we get digital literacy right in 2022. So this includes access to the portal, includes all kinds of elements of engaging in your health record, and we just know that we need to do this. So I think the solution we're finding is not someday digital literacy, but very soon at this time, digital literacy, and we just wanted to make sure everyone was aware of that. Does that sound like a good solution? Okay, it's crickets today. Next slide, please. All right. Any questions before we go on? There's to our next domains. Okay, next slide. And next slide. Yoo-hoo! Health insurance status. So this is the documentation of the presence and type of insurance. We do want to state, and I want to give a nod to our amazing member of our team, Hamali, and our amazing pre-existing team, Asha and Linda. We're doing a lot of work right now to ensure that all of our approaches align with federal survey methodology, including NHIS, including the American Community Survey, including anything that's kind of a longitudinal study that's really critical for those public health use cases. So we're not just doing, in the past, we've done domain level searches, like, can I find this question? We are actively auditing all of those different comprehensive national approaches to make sure we don't miss anything. So I just want to let everybody know that that's work in progress. It's labor, but it's labor that needs to be done. Next slide, please. And again, this is to make sure that if we miss.
Sarah.
Hi, yes?
Sarah, hi. The previous slide.
Okay.
Could you comment about the concept insurance? Those of us who have thought about insurance for decades know that a lot of what we call insurance really isn't. And so I'm wondering, in the second bullet, what kinds of health insurance or healthcare coverage do you have? I'm wondering about your expert input about whether healthcare coverage would actually be a better term for this domain.
Well, we are not covering gaps in or underinsurance in this domain. Right now, we're only covering the presence yes, no. Is that an answer to you? Because health insurance.
Yeah, coverage, yes, no, will include, for example, Medicaid, which is not insurance.
It is for the purposes. So, for the purposes of this federal definition, I'm a little bit confused. So how, you mean it's not, it is, how is it not insurance? Help me.
Premiums are not based on health risk. There aren't any premiums. Health risk is not, well,
Oh, I hear what you're saying.
let me be careful. A lot of people on this call know that social risk is now being debated vigorously in the literature as a factor for costing out what will be paid in Medicaid. So I'm just saying that from a technical, professional perspective, Medicaid is not insurance. If the government calls it insurance, okay. So that's one of the reasons I'm raising the question, are we all clear here that the domain that we're talking about includes at least one major type of coverage, which is not in fact insurance, and therefore coverage is a broader term and might be a better term for our use. What do other people think about this?
This is Janice. I butted in. I'm sorry. I agree, Lucy. I serve on Washington State Notices Work Group for the Healthcare Authority, and we use the term coverage.
So what would
Yeah.
you call, I
You
mean,
couldn't say Medicaid coverage. You could if you wanted just to say that there. I don't know what you think about that, but or health insurance / coverage or.
CHP isn't insurance either.
right, so
Right.
I want to be careful that we do follow federal definitions, and according to this federal definition, it's health insurance status is the name, and it's the documentation. So maybe do you want me to change the name of the, I'll think about what I can do, but I am bound to how it's described in this US Census and in American Community Survey and in NHIS, which does call it, like now we're going to be talking about health insurance, right?
You
So,
do have it in the second bullet question too. What kinds of health insurance or healthcare coverage do you have?
At present, the domain is defined as health insurance status. We can investigate other possible domains, but domain names, but I would just need support, and I would have to cross-check them with the other federal definitions that we have.
This is Soraya Asar. Sorry, I had to come and go back, so I hope I didn't miss something key to this. But when it seems like I know what we're saying technically or sticking to a definition of insurance, Medicaid might not fall into, but I think the question is if it's health insurance, health coverage, and looking at the choices that you have here, when you look at there's two places I would look to, the source of payment typology and some of the HL7 fire coverages. Medicare is listed in the source of payment typology. So it's a source of payment, not specifically health insurance. I wonder if looking at it that way might help the discussion.
So it might. We just have to make sure that we have, because these are one single question that covers all of them. So, and these are existing questions, and this is one example. So as long as we find a name that encompasses everything, right, all of it, then we are fine, right? And
I wonder, healthcare coverage seems like it might be a good thing to think about.
So it would have to be healthcare coverage status because it is a status statement.
Right.
And again, that would be fine. I think as long as, again, we have a definition for things because we have a current And that's absolutely fine, I think. We'll look at healthcare coverage as an
Yeah.
option.
That might cover a whole host of things, because if you look in that one HL7 table, they have things in there like what am I trying HIV programs or breast cancer screening, so people can get their coverage for specific, and that's the other thing too. So say there's a program for HIV. So I have coverage if my care is related to HIV, but what if I'm also pregnant? Then I don't have coverage for that. So that might be something to kind of think about as well.
I
Yeah,
think
you can certainly have insurance and not be covered for pregnancy. One of our American scandals.
but are we talking about several different things? And because you have to have health insurance, and within your health insurance, they'll tell you what services are covered. And so when you're looking at the EMR, even the question, if you're asking a patient a question, what's in the EMR that they're going to document again is health insurance. And what do you typically ask your patient? Do you have health insurance or do you have health coverage?
The question I get as a consumer is, how are you planning to pay for this?
Yes, exactly. Exactly. It's that.
I know. So, but if you look at the question methodology and this is what we have to go off of. We're looking at how it's phrased. Okay, so I want to just honor this conundrum. We have to solve it in ways that are commonly defined, right? I hear you, right? And so right now, health insurance status has been our kind of meta statement. It might need to be something broader to cover the complexity of non-classically insurance type programs, but we also have to be bound to how it's described and named as a general domain in other instances. So I promise.
Thank you, Sarah.
Yeah, I promise to come back with next week and have some updates there. All right, next slide, please. They do not. Cash payments would not qualify as insurance or other coverage. But they are covered as a concept within medical cost burden.
Yeah, if you're really sophisticated and somebody says, how are you going to pay for this? You could answer, well, I'm self-insured.
Yeah, you could. You could. All right, so we have this hasn't changed since last time. Next slide, please. This has not changed since last time. Again, everything in bold already exists, but there is no generic meta concept, so that's what we're proposing. That's not in bold. Next slide, please. Okay, so that's health insurance status, health insurance / coverage status. So we'll figure out that in time, but those are the updates there. Really thank you for that conversation. And we'll just put our little thinking caps on and see if we can solve it in a way that makes sense without breaking precedent, so we don't deviate from the kind of norms of how it's been talked about so far. And these are specifically in person, in patient interfaces that we're speaking of, which may not always cover the complexity, but I want to honor that. Any other questions before we go forward? Thank you, Teresa. Yes, so we have the generic health insurance information and then coverage status. Coverage type. Okay, that's helpful. Thank you. Next slide, please. And next slide. Well, so Tom, I wouldn't say we're circling because we have defined them. Well, they're circling insofar as it's a Venn diagram, right? So we have the reason why we're covering medical cost burden and health insurance in the same breath is because they cover some of the complexity that we're talking about right now, right? Do I have coverage of any type? Yes, no, right? And then the outcomes when my medical burden, my medical cost burden is excessive, right? Because the problem, as we talked about in the kickoff, is being under and uninsured does not mean you have medical cost burden. It just puts you at risk, right? So this is all part of our medical cost burden and health insurance / covered kickoff. So this is why these two terms in the literature are really important to define. Affordability is the intersection of, well, that's really difficult. So we covered affordability partly within our work on material hardship, right? Can I afford this thing? And medical cost burden is the presence of the debt and the strain, like from any of the ensuing, like I gave the use case of the individual with the coronary event, right? Preventing care because they could not afford it is in the medical material hardship element, and then the cost incurred from the uninsured hospital visit would be the actual medical cost burden. Tom, did I answer your question? Healthcare access, are you able to find and receive the healthcare you need? That is not happening right now. And I want to remind folks that part of why we're addressing this is because many of these concepts were put under the same concept of health insurance and security in a submission this fall, but that's a whole separate concept. And so as terminologists in this space, we realized that we needed to really clearly define the different like swim lanes and make sure we had an understanding.
Sarah, since medical cost is a major cost of bankruptcy, should we include, are you contemplating, or are you legally in, or something to reveal that the person in this encounter considers themselves in bankruptcy because of medical debt?
We do have, we did cover bankruptcy within our financial insecurity build in the past. And so, and there are questions, there are questions regarding the presence of bankruptcy and medical debt in some of our screening questions and answers. Absolutely. So if that was a specific question that one wanted to arrive at, you could either couple the questions from financial strain and medical cost burden, or you can ask the specific question regarding bankruptcy and medical costs coexisting. Ooh. You guys are so smart, keeping me on my toes.
You're showing us what a good memory you have.
Yeah.
I mean, the rest of us don't think about this 24/7, and you clearly do, and it's really wonderful to reveal what's in your brain.
It's scary up there. So, so Tom, that would be some of the Venn diagram of medical cost burden and material hardship, right? And those questions there are questions akin to that in the screening question answer set. And we do encourage all of you, remember, so next meeting is when we start the end-to-end review. So it's really important that you go there and ferret them out and make sure that we have things that look complete. And if you feel like there's something missing and there's a standardized and disseminated question that meets needs, we would love to have it be part of our set. Please, please, please submit it. So this is kind of what Tom was saying. So delaying care, those concepts they're very similar concept to that deeper. This is just one example of the many questions we have within the medical cost burden set. So there are elements that address that within our screening questions and answers. Just delaying care without cost burden, again, is covered in material hardship. Like I'm not doing this thing because unless it's specified that you actually have debt, it's not here yet. We do have unable to afford elements currently, and we should go to the next slide. We continue to go, again, this is just regarding screening. We do have we still are holding space for the material hardship codes that we've had in the past that cover the unable to afford. But we're narrowing in on the difference necessarily being really that presence of debt, but these also apply as possible concepts, and they're already in because of previous builds. So we are working with our subject matter experts on the boundary lines here. Next slide, please. These are some of the specific elements, and you can see medical cost burden. We've submitted as an inclusion term and a subtype of financial insecurity. That's how we first talked about it. And so that proposed ICD-10 code for financial insecurity would apply. And then you have the excessive out-of-pocket medical expenses, excessive medical debt, and then a pre-existing code that we had in the past, which is financial insecurity due to medical cost burden. Next slide, please. Are we just naming three pieces of equipment? There's precedent for definitions of excessive. We try to use common terms, Tom, but there is, yeah. So we're trying, if we go back a slide, denied additional treatment due to medical debt. That does happen. That it would likely be, sadly, a different concept than just medical cost burden, but that's a very sad one. I just had to do the shop around to try to get my patient a colonoscopy because of just that. A patient had too much debt at existing surgeons, and so we had to find somebody that was willing to take care of them with a history of really significant concern. So that happens, but it would likely be a different domain, a very sad domain, but a different one. Yeah, how about being hounded by collectors? Also, sadly, a different domain. Tom, so this is something, there is precedent for the word excessive. We really are trying to drive to this sense that the difference between the amount of debt and the means to pay for it. So simply having debt does not mean you have medical cost burden. It is the difference between the resources you have and the debt you have. If you earn $1 million a year, a $20,000 bill for an elective surgery out of pocket is not a problem. If you earn $25,000 a year, admission for a coronary event is backbreaking. So that's where that excessive term comes in. We can't just state that the debt exists and represent the concept. So that is where that comes in. Tom, we'll talk about it more on the 8th in our intervention council. Hopefully you can help me figure out if we need to do better there. Next slide. We are losing folks. We're at the top of the hour. We're almost done. So we have able to pay for healthcare needs as our meta goal, and then able to afford medicine as a carryover from material hardship. Again, so this is, we try to bring things forward, and Lucy, we try to invoke memory and auditing with our carefully, like all of our careful change of registers in order to make sure that we're thorough from past build. And I believe that's it. So next slide. I did mention that we're working with SMEs to differentiate material hardship from medical cost burden, so which is the ability to afford from the presence of medical debt. We're still having that conversation. Next slide, please. And I think that's it. Questions? And next steps, next slide. All right. Able to afford medical devices, DME for care phones. Susan, that's really important. I want to make sure that we cover that. So I will go back and make sure that that is, we have able to afford healthcare term in general. We have the specific medication one because of our previous work in material hardship. Medical devices, so important. I think about a patient of mine who has HOMO2 and uses CPAP and currently can't afford their device. So that's a very, I almost always have a patient example. So I think that's really important. So catch up is needed on materials and recordings. This is available for recording. So I'm going to mention that in a second. And maybe if Mark is still on, maybe Mark can talk to that a little bit. He might have dropped off. No, he's still here. But the biggest thing is, before we start end-to-end review, please submit your concepts. So if you have tools, submit them, review the masters, they're updated, get all of your information to us. So when we head into end-to-end review in 2 weeks, we do it with the most robust set we possibly can. Mark, do you want to address Gail's question?
Sure. So I sit on the Interoperability Standards Work Group, and we were asked to pull together some presentations from subject matter experts about disability status, functional status, and what was in US CDI version 3 as mental function, but we're recommending a name change there. And so we discussed that at length. We discussed different possibilities. I think most of the work will be done on the back end by ONC, looking at different standards and instruments. The one thing where we had and we haven't, I should say, the work group itself has not finalized a recommendation yet, so I'm really just giving you a sense of direction. We thought that on disability status, that data, it's very important that the data be self-reported by the individual. And from the subject matter experts we had, the recommendation was to use the 6 questions from the ACS, which I think is the American Community Survey, and a 7th question on communication from the Washington group. And then there was a long list of different possible standard sets that I think we are recommending that ONC talk with different stakeholders about. That's my best window into one piece of work on this.
Thank you. Did you mention a particular work group? Like which work group?
Yes, I did. It was the Interoperability Standards Work Group, and that is considered a subcommittee of the Health IT Advisory Committee under the Office of the National Coordinator. Does that make sense to you, or should I explain a little further?
No, that sounds good. Okay. I think that'll give me the information I need. Thank you very much.
Okay, and you can reach out to me further if you wish.
Okay.
I'm seeing a question from Sarah, from Susan, about diving into differences for developmental and intellectual disabilities. We covered it broadly, so I think that would come under what we're proposing to name cognitive/mental status. What the particular value sets would depend on what ONC chose on the back end.
Mark, thank you for being our ever amazing friend in Central Spaces. So thank you so much. All right, friends.
You're welcome.
I think that we have no technical update today. The biggest objective is for you to submit concepts. Thank you for all your robust commentary. All of those elements are logged, as you know, and we have homework to do to come back and address some of your concerns with missing things and possible refinement of terms, and we will see you in 2 weeks.
Thank you.
Sarah.
Bye.
Thank you. Bye.
Bye.